So the next health concern that we will have a discussion on is hypothyroidism. So now everything is secretions of thyroid hormone is now less. So there's a more slow response, body response with hypothyroidism. I do want you to look at page 1271, chart 63-6. For signs and symptoms of hypothyroidism on each system. For example, for cardiac, there would be bradycardia, dysrhythmias, enlarged heart, etc. So remember, all these more or less opposites of hyperthyroidism. So signs and symptoms of hypothyroidism is due to a decreased metabolism from low levels of thyroid hormone. Now, thyroid cells, they do not produce enough thyroid hormones due to cells, they might be damaged and cannot function normally. Sometimes thyroid cells are normal. However, a decrease in iodine and tyrosine which is needed to make thyroid hormones is insufficient, which is why when you look at your salt at the store, it has iodine in the salt, so you can get your recommended daily amount. Now, thyroid hormone is low or absent in this condition. It is lower in the blood. There's a lower metabolic rate as well. Remember, everything is slowing down. There's essentially a decrease in metabolism. The hypothalamus and the anterior pituitary gland, it does make this stimulatory hormone called TSH, and this triggers the hormone release from the thyroid gland. And what happens is the TSH binds to the thyroid cells, and this leads to an increased size of the thyroid gland. And this is what actually forms the goiter, the picture that we looked at previously. And so the goiter forms, it gets enlarged, and despite this enlargement, there is still a low production of thyroid hormone, even though that the gland is enlarged. Tissues and organs are impacted by low metabolism rate due to hypothyroidism. What happens is cellular energy is now diminished, is now decreased. Metabolites like compounds of proteins and sugars, they begin now to increase inside the cells. And this increased buildup produces mucus as well as water, and it forms a kind of a cellular swelling or edema. And this does change the organs, our body systems, the organs itself. It changes the texture. The swelling or the edema is mucinous, mucoid, or we also refer to it as maxedema. And this is not caused by water alone, by the way. The patient's appearance, it changes due to the edema or the swelling. There's non-pitting edema everywhere, such as the eyes, the hands and feet, between the shoulder blades. The tongue also thickens. There's also edema in the larynx that leads to that husky voice that you see in these patients. And basically physiological functions just decreases. It's not that hyper response that we talked about with hyperthyroidism. These patients are also at risk for developing myxedema coma, also aka hypothyroid crisis. Um, it occurs when the hypothyroidism is poorly treated or not treated at all. Um, the mortality rate is very significant with these patients. Now, as far as decreased metabolism, um, the heart muscle becomes flabby, basically. The heart chamber size it does increase. As a result, these patients end up with a decreased cardiac output, which when you have a decreased cardiac output, that leads to decreased perfusion as well as gas exchange to the brain as well as other vital organs. There is a decreased cellular metabolism that worsens. And then, of course, tissues and organs will begin to fail as well. This can be caused by other advanced drugs or essentially other conditions as well. Now, I want you to review the etiology in this section. Um, Possible causes, there's low iodine in the soil, etc. So there's some additional information. Look at also the incidence and prevalence. It is greater or seen more likely in women versus men, etc. See page 1272, table 63-2 for causes of this condition as well, without me having to actually read through all of it. So this is what this condition looks like. This is the maxedema that you will see in these patients. So just take a look at that. So hypothyroidism assessment. This condition is mostly managed in the community, but initial diagnosis might be managed in the acute care setting, especially with complications such as maxedema comes about. When you're taking a history with these patients, you will note that signs and symptoms may have developed slowly. What you want to ask these patients is about their activity level now and compare it to about a year ago, because typically the activity level begins to decline. So they might be sleeping more. You want to obtain their sleep history, as these patients sleep many hours. Want to assess for signs and symptoms as far as generalized weakness, anorexia, muscle aches, paresthesia, constipation, cold intolerance. Also ask about the need for more blankets at night, clothing, even when there's warm weather. Want to watch for subtle signs and symptoms, especially in older adults. And again, I want you to look at the other signs and symptoms and ask these patients about these possible issues. Ask about drugs that impair thyroid hormone production, such as lithium, something you probably learned about in your psych class. Also, there is thiocyanate drug, amiodarone, etc. These types of medications that can impact thyroid hormone production. Look at page 1272 for that information or additional information. Ask about past treatments for hyperthyroidism as well, because remember, if they're treated for hyperthyroidism, then they're probably going to develop hypothyroidism as a result. As far as physical assessment and signs and symptoms, see page 1271, chart 63-6 for signs and symptoms, and psychosocial assessment. Note that a goiter can indicate the presence of too little thyroid hormone or excessive amounts as well. As far as laboratory assessment, Lab findings are the opposite of hyperthyroidism. The T3 and T4 levels are decreased. The TSH levels are increased in primary hypothyroidism. However, can be decreased or normal with secondary type. So take a look at page 1272, table 63-2 for primary, secondary causes of hypothyroidism. Older adults have a lower than normal thyroid hormone, so keep that in mind. So only treatments with these patients, these older patients, is when they exhibit some signs and symptoms related to hypothyroidism. Otherwise, you wouldn't bother with them. So this information is very important because most of these issues can increase morbidity and mortality. So the priority collaborative problems for patients with hypothyroidism include decreased gas exchange and oxygenation, hypotension, and reduced perfusion. Remember that cardiac output is reduced even though the size of the ventricles have increased. There's a reduction in cognition and potential for complications of myxedema, coma as well. So these are our priority collaborative problems that we want to focus on. And these are measures we want to ensure happens with these patients, especially with respiratory and cardiac compromise, since they are serious. The most common cause of death with patients in myxedema coma is respiratory failure. So we want to improve gas exchange. We're applying oxygen if needed for hypoxemia. We're listening to breath sounds. These patients might be possibly intubated. And we want to avoid sedation in these patients as it can further compromise their respiratory status. Sedation drug doses must be adjusted with these patients if you're going to give them anything at all. But we certainly want to assess their respirations before administration of this medication. We also want to prevent hypotension, keep the heart rate greater than 60 and the blood pressure close to normal. Also ensure no dysrhythmias are present. We want to assess for peripheral edema or neck vein distension. So the nurse should watch for complications like shock and intervene appropriately. Also looking for heart failure with these patients. And so if shock is present, you will see a low blood pressure, decrease in urine output because there's decreased perfusion of blood to the kidneys. There's also change in mental status. Remember, there's a decrease in cardiac output, so they're probably not perfusing adequately to the brain. Want to ask the patients about chest pain, shortness of breath issues, as these patients might have cardiovascular disease. These patients will be started on Thyroid, which is a synthetic hormone, and it is started at a low dose, but it is gradually increased or titrated upward over time. Now, patients with severe signs and symptoms of hypothyroidism started on the lowest dose of thyroid hormone replacement. Otherwise, a high dose can lead to complications like severe hypertension and heart failure, as well as an AMI, acute myocardial infarction, or headache. If these patients have myxedema, if they have myxedema coma is severe, IV medications is likely going to be required. to try to reverse this as much as possible, as quick as possible. We do want to assess for chest pain, shortness of breath before initiating treatment. We want to teach patients and family members about signs and symptoms of hypothyroidism. We want to support their cognition. After starting the thyroid hormone treatment, these patients, they might be severely lethargic, drowsiness. They may have memory issues, deficits, poor attention span, etc. I'll just read additional information in that section. These things should improve. Actually, that's what I meant to say. After starting treatment, I should say before treatment, these patients will be severely lethargic, drowsy, poor memory, deficit, poor attention span, etc., but should improve after therapy is started. Approximately 2 weeks, and this must be explained to patients and families so that they will be realistic as far as outcomes. And of course, you see the little squiggly line that I wrote here. That means approximately whenever you see that. Possible contributing factors to myxedema coma is acute illness, surgery, as well as chemotherapy, etc. Read additional information. Issues that occur with myxedema coma. There's coma, of course, respiratory failure, hypotension, hyponatremia, hypothermia, as well as hypoglycemia. Remember, everything is suppressed with hypothyroidism. Want you to take a look at chart 63-7, page 1274, for emergency care of patients with myxedema coma. As far as care coordination and transition management, with hypothyroidism, can be managed across care settings depending on the severity of the signs and symptoms. In the home care setting, if cognition is impaired, ensure home safety measures are instituted. If the patients are fatigued or weak, we should encourage them to live on a single floor for at least a short period of time so they don't try to negotiate or navigate steps and fall and injure themselves. We also want to teach them about the need for layered clothing due to this cold intolerance. They get cold, which is the opposite of hyperthyroidism. They have heat intolerance, but these patients have cold intolerance, so they get cold pretty easily. Teach patients about proper drug therapy administration, self-administration, or their designated caregiver. Very important to teach them about thyroid hormone replacement treatment for the rest of their lives, and also about its side effects. Want to also teach them about hyperthyroid and hypothyroidism signs and symptoms. All a part of your patient teaching. Also, what is important, thyroid hormone replacement drugs can interact with many over-the-counter drugs. So they should be consulting their pharmacist or their physician before using anything new, any over-the-counter drug. I want to also teach them about a well-balanced meals, especially fiber, in order to avoid constipation in these patients. Fiber supplements can interfere with absorption of thyroid hormone replacement drugs, so be really careful about the fiber supplements, not fiber foods, but fiber supplements. These patients should take thyroid hormone replacement drugs on an empty stomach at least 4 hours before meals. Teach patients and the families that improvement of signs and symptoms varies once treatment is started. So patience, patience, patience. Um, Two of the easiest parameters to use to determine if thyroid hormone replacement is effective. Um, if it is effective, you should look at their sleep patterns as well as whether or not they are constipated. That is, if the patient requires more sleep, or if the patient is more constipated, then the dose would need to be increased because they're not really improving. And of course, the reverse is also true. If the patient is having too many bowel movements and they are getting a significant amount of less sleep, then the dose should be titrated downward. So again, look at bowel movements as well as their sleep patterns because the dose may have to be titrated. As far as healthcare resources is concerned, ensure these patients have someone to stay with them at home, at least for a short period of time for support as well as safety. A home healthcare person or nurse will have to perform a thyroid dysfunction focused assessment when they come out. And see page 1274 chart 63.9 for that additional information about the focused assessment. So this is a condition that I don't really have to cover. It's on page 1275, thyroiditis. Wasn't on my scheduled syllabus, but I do want you guys to just read through it. Please just take a quick read. Could be on your HESI, not on your test, but take a read at that as well. This is another condition that I don't have to cover, but want you to look at thyroid cancer, take a good read at this one as well. Again, just in case it shows up on your HESI. So the next health concern we will take a look at is hyperparathyroidism. So the parathyroid glands maintains our calcium as well as phosphate. Very important to remember. Serum calcium is maintained in a very narrow range. Keep that in mind as well. Doesn't have this wide range like you see some electrolytes or minerals. Now, when you have increased PTH levels, which is what is produced by your parathyroid gland, it acts on the kidneys, causing the kidneys to hold on to calcium. This is what is actually happening. The PTH levels are increased. This hormone actually acts on the receptors of the kidneys, and it would cause kidneys to hold on to calcium. But it will hold on to calcium but excrete phosphate, and this can also lead to increased hypercalcemia, excuse me, because remember it's holding on to calcium. But since it's excreting your phosphate, there would be a decrease in phosphate or hypophosphatemia. Now, that is one way to control calcium and phosphate. Now, as far as the bones are concerned, because the bones are involved in this process as well, when the PTH levels are elevated, this will lead to increased bone resorption, or AKA loss of calcium. And this is done by an activity known as decreased osteoblastic or bone production activity. And there is also an increase in osteoclastic or bone destruction. So the osteoblastic is when there is an increase in bone activity, but the increase in osteoclastic activity, which is more of a destruction or breaking down or bone destruction activity results. With this process in mind, the calcium and the phosphate levels are released into the blood, causing a decrease in bone density. So bone density will be decreased, of course, and when that happens, these patients are at risk for fractures. This does result in chronic calcium excess. You have a lot of calcium or hypercalcemia in the blood. And it is this excessive amount of calcium that will now be deposited into our soft tissue. Hence, the kidneys and the bones, along with PTH, are involved in this process of regulating our calcium and our calcium and our phosphate. Now, there is a primary hyperparathyroidism, and it appears to result from, as far as etiology, parathyroid gland not responding to that normal feedback of serum calcium levels. Remember that negative and positive feedback loop. So apparently, or it appears rather, that the parathyroid gland is just not responding. Even though the calcium levels might be normal, it's just not responding. Remember, if there's adequate levels, then the negative feedback is supposed to kick in and stop creating conditions to increase the calcium levels. If it's not enough calcium on board, then the positive feedback loop will kick in, and this is when the kidneys will be affected, thereby increasing calcium, excreting phosphate, and the same with the bone activity. You know, remember the osteoclastic and osteoblastic activity. So just go back and read that information. The most common cause of this condition is a benign tumor of the parathyroid glands. See also page 1276, table 63.3 for causes of hypo and hyperparathyroidism. See also page 1276, chart 6310 for lab values with respect to parathyroid functions. Signs and symptoms of hyperparathyroidism. Signs and symptoms of this condition is possibly related to the effects of either excessive PTH or an increase in calcium levels. Other signs and symptoms, you might see bone fractures, or FX means fractures. Remember, calcium is taken from the bones, that osteoclastic, and that makes the bones weaker. There's also weight loss, arthritis, psychological stress, constipation, kidney stones. Remember, this increase in calcium in the blood can lead to, of course, kidney stones. There's also GI signs and symptoms. There's increased serum gastrin levels that is caused by an increased calcium. There's also peptic ulcer disease. When the calcium levels are greater than 12 milligrams per deciliter. There is psychosis with change in mental status, there's coma, and ultimately death, etc. Read the additional information. If these patients receive radiation to the head or the neck, the parathyroid glands and other structures can be impacted by that treatment. Serum PTH, calcium, phosphorus levels, and urine CAMP levels can determine if a patient has hyperparathyroidism. Bone density tests and x-rays are also done as well. As far as interventions are concerned, surgery is a treatment of choice. However, if a patient is not a candidate for surgery, drug therapy to help control signs and symptoms will be instituted. As far as non-surgical therapy, for patients with a more mild disease, hydration and Lasix or diuretics is given to aid in excretion of calcium. When you give the Lasix and the hydration, and when these patients pee, they're peeing out calcium, which hopefully will lower the serum calcium levels. These patients are given IV normal saline in large volumes to help in this case. For more severe signs and symptoms, the physicians will use a drug called cinacalcet. And what this does, it binds with calcium sensitive receptors on the parathyroid tissue. And so if it binds to the receptors, what will result is a decreased PTH production and release. This will in turn result in decreased calcium levels. Other minerals are stable. This will decrease the progression of PTH-induced bone issues as well. We want to observe calcium serum levels and also watch for hypoparathyroidism. So again, you're treating the hyper type, but that treatment can result in the hypo type, hypoparathyroidism, that is. If we cannot use the cinacalcet, then oral phosphates used to inhibit bone resorption and interfere with calcium absorption. Let me see if I read that to you right. So if cannot use the oral phosphate used to it. All right, yeah. So our oral phosphate is used to inhibit the bone resorption, and it does interfere with calcium absorption, rather. Calcitonin also decreases the release of skeletal calcium. So when this drug is given, you won't have the osteoclastic activity of the skeletal system. So the calcium levels will be reduced. So calcitonin decreases release of skeletal calcium, and it increases kidney excretion of calcium. However, to be most effective, this particular medication, calcitonin, is given with some of your glucocorticoids type of medications. Then it becomes more effective. We want to monitor intake and output and hydration at least every 2 hours with these patients. If they are peeing out too much calcium, then we want to look for signs and symptoms of hypocalcemia, tingling and numbness of the muscles. Now, preventing injury is important due to a loss of bone density. Remember that osteoclastic activity, all that calcium is being taken from the bones, leaving them vulnerable. So bone density is weakened. So there's an increase in fall risk and fractures, and of course your unlicensed assistant personnel can help in handling or help with transfers and ambulation with these patients. As far as surgical intervention, there is a surgery, parathyroidectomy is the procedure of choice. And of course, labs must be close to normal, just like your thyroidectomy. Labs must be close to normal before surgery is undertaken. If the patient, of course, has a cancer of the parathyroid gland, then the glands are removed totally. Nursing care will be the same as far as surgery is concerned, as you have read about with thyroid surgery. Now, we talked about PTH, the hormone PTH. PTH over production leads to an atrophied, or when the gland becomes smaller, atrophy. Leads to an atrophied gland, but it can return to normal over several days to weeks. So you just have to give it a little time. We want to observe for low calcium after surgery for these patients, and also look for a condition we call Trouser or Schott's sign. As far as a Trouser sign, from about 1 to 4% of normal patients would test positive for Trouser signs of latent tetany. This sign may be positive before other manifestations of hypocalcemia is seen, such as it's an early indicator of this patient having a low calcium, this Trouser sign. So you will see other manifestations of hypocalcemia is hyperreflexia and tetany. As such, it is generally believed to be more sensitive, about 94% of the time. So it is a really great test to test for. Now, this test is better than the Schott's sign, which is about 29% for hypocalcemia. So I would use the Trouser sign as a tool, as an assessment tool over this particular tool, the Schott's sign. This is actually pronounced a different way, but I just can't remember how I used to pronounce it. But the other test, the Trouser sign, is more accurate, more reliable, if you will. Now, the Schott's sign is done by tapping the skin over the facial nerve about 2 centimeters anterior to the external auditory meatus. And what happens is the ipsilateral, or the opposite, or no, same side, ipsilateral, contractions of facial muscles is essentially a positive sign that there's low calcium and it needs to be replaced as soon as possible. We also want to assess for voice patterns, hoarseness due to possible damage to the laryngeal nerve. If hyperparathyroidism caused by hyperplasia or over tissue growth, then if 3 glands are involved, and well, let's see. So if a patient has a hypothyroidism, which is caused by hyperplasia or tissue overgrowth, 3 glands and half, because they're four, is removed. If all four glands are affected, then all glands are removed. And a small portion of one of them is actually placed in the forearm. If it's placed in the forearm, it still can produce PTH, and which can maintain the calcium levels. Remember, that's one of the functions of your parathyroid gland, is maintaining your calcium levels. If these measures fail, then lifelong calcium and vitamin D must be taken with these patients. So as far as hypoparathyroidism, so now we're looking at the opposite. There's a decrease in function of the of the parathyroid gland. There is an iatrogenic type, and this is a surgical removal of the thyroid or parathyroid gland. There is also the idiopathic type. This one occurs spontaneously and is thought to be in autoimmune related. It can also result from hypomagnesemia or low magnesium. And the interventions is basically to correct the calcium, administration of vitamin D, and to also treat hypomagnesemia. So basically replacements of these minerals. Now, hypoparathyroidism can be due to a lack of PTH secretion or a decreased effectiveness of PTH on those target tissues. So target tissues are not responding to the PTH hormone secretions. This can lead to low calcium. Also hypomagnesemia, I talked about being a cause. Hypomagnesemia, as seen in patients with, for example, malabsorption syndrome, which refers to a number of disorders in which the small intestine cannot absorb enough certain nutrients and fluids. Nutrients that the small intestine often has trouble absorbing can be your macronutrients, such as your proteins, your carbohydrates, and your fats. Of course, your micronutrients, that would be your vitamins and minerals, or both. Also can be caused by CKD and malnutrition. So when with low magnesium, it actually suppresses PTH secretion and interferes with the effects of PTH on the bones, which will also have an impact on the kidneys and calcium regulation. As far as assessment is concerned, we're asking about the history. I want to ask if they received head and neck surgery like we did before, radiation, as these can lead to hypoparathyroidism. I want to ask about signs and symptoms of hypoparathyroidism, such as mild tingling and numbness to the muscle, tetany. These patients are patients with a mild to moderate hypocalcemia with signs and symptoms. We'll have tingling and numbness around the mouth, also of the hands and feet. And for more significant low calcium, there would be positive severe muscle cramps. There's also spasms, and this is the more severe types or signs and symptoms. There will be spasms of the hands and feet. These patients will also have seizures without a loss of consciousness or incontinence. So there will be no loss of consciousness or incontinence with these seizures if the condition is severe enough. They may also have signs and symptoms of psychosis and irritability. Look for excessive or inappropriate muscle contractions that leads to the finger, the hands and elbow flexion. Uh, this is important because it is basically an early sign of tetany. Um, you may also find bands or pits that actually encircle the teeth. And what this means is there's a loss of calcium in the tooth and also enamel. Um, some of the tests that are done, EEGs, looking at possibly seizure activity, blood tests, looking at your PTH, calcium levels, phosphate, CT of the brain might show calcifications due to chronic hypocalcemia. We also, well, I talked about this, some of the labs that you might see the physician order to be drawn is your calcium, phosphorus, also your urine C-amp labs, and these labs can determine hyperparathyroidism. Talked about the ECG, well, talking about it now, ECG changes. So this is also very important to have as an assessment tool. Also, we're looking at vitamin D, magnesium to assess hypoparathyroidism as well. As far as interventions are concerned, treatment of hypoparathyroidism involve correcting hypocalcemia, vitamin D, and magnesium, which I discussed earlier. Want to treat the following deficiencies with these conditions will require IV calcium, vitamin D deficiency, and so if there's acute or severe hypocalcemia, we're treating them with IV calcium, vitamin D, and oral calcitrol. As far as decreased magnesium, we're treating them with mag sulfate IV. And so these patients will be taking calcium long term for treatment of hypocalcemia. As far as long-term treatment for vitamin D, there's a medication called oral ergocalciferol. They're taken every day. The dose is adjusted to keep calcium level normal to slightly hypokalemic. We also want to keep calcium low enough so as not to cause renal stones. So we want to keep it kind of on the low side, but not too low. As far as teaching, drug therapy information, eating foods that are high in calcium, low in phosphorus. We want to avoid, if we're talking about eating foods high in calcium and low in phosphorus. So as far as the phosphorus is concerned, avoid yogurt and processed cheese due to the high phosphorus content. Also, stress treatment for hypoglycemia will be lifelong as well. And I think that is about it for these conditions. I'm going to upload this slide to the cloud, and hopefully you all will be able to access this presentation. And I will try to do the other one as well, but this is what I actually wanted to cover in class. So at least you have this for the time being. Thank you, everyone.